Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Brad and Mike. How are you guys doing today?
Very well, sir. Doing great, man. Glad to be here.
Perfect. So today I would like to talk about something that's 100% both of your alleys, is ether. And the reason why is just kind of word on the grapevine is people are manufacturing ether for use in surgery. And since both of you are medical professionals, I assume that you'd be able to tell me about the good and the bad and how smart is this?
Sounds good.
Perfect.
All right.
Perfect. So, Mike, I would like to ask you first, why on earth would anybody do this? I already have IV narcotics. This sounds like a horrible idea. And, are they just murdering people out there on purpose or what?
Yes, sir. No, yeah, it's a great question, and it's a great one to springboard off of. But I guess let's look at it maybe a little bit in the big picture. And when we look at medicine, especially in the austere setting, there's been a variety of terms thrown around here recently: improvised medicine, primitive medicine, and those really hit some sensitivities, I think, once in a while, especially with the more clinical professional crowd, and it should. I look at ether as historical medicine. It's the foundation for all gas anesthesia inhalation. And, as Brad so eloquently puts it, it's your run home to mama drug for inhalants, just like morphine is for an analgesic. I think it's simple, it's safe, and just as with any other drug, as ketamine or midazolam, as long as you understand the dynamics, the drug profile, and the risks associated with it, it can be a very effective surgical anesthetic for general anesthesia. I think another reason to use it is you might not have any other choice. It might be the standard of care in that location that you're working in. One great thing about ether is it has worldwide availability. Not only on the market in a lot of the pharmaceuticals, especially in the subcontinent and the Indo-Pacific, but I would say with some of the priority one NATO countries nowadays, especially those that are most at risk in this environment, especially with a hot war in Europe right now. I do know and understand that several countries are, practicing your basic high school chemistry with a little bit of ether. Is it your first go-to drug, especially if you had IV TIVA or total intravenous anesthesia? No, it would not be. In my opinion, if you look at or use the PFC good, better, best analogy, this is far to the left of good. However, again, it's very safe. It's easy to manufacture. It's easy to understand. It is the foundation for historical anesthesia. And again, being in a place that you might not be accustomed to, it might be the standard of care or the only standard of care there. So the better understanding of ether anesthesia, especially even in our own settings here in our own hospitals, I think will give us a better clinical understanding of current medicine as well.
Nice. So Brad, as the drug expert on the panel here, would you mind telling me everything I need to know about ether?
Well, I don't know about everything because, we only have so much time, but like Mike said, it's the hallmark of all anesthesia. It's where the actual anesthesia profession actually started, was way back in 1846, with Dr. Morton up in what they now used to call the Ether Dome up in Mass General, had the first successful use of ether as far as using it as for surgery, because before that, really, surgery was pretty barbaric. And it really opened the door for everything as far as how surgery can now progress and more invasive techniques and just really open the door in all kinds of different kinds of ways. Since it's such an old drug, a lot of times people write it off, this is all the way back to the Civil War and things along those lines. And why would we be using this thing at all? Kind of a deal. We have all these, newfangled things now to be able to use instead. And, that's all true. in this country. But like Mike said, in developing countries and a lot of other places, this may be it, because this may be all that they can afford if they can afford this. And, a lot of times people go in, they do like, Doctors Without Borders kind of things. And they go into these other countries and are pretty shocked to see when they walk into a quote operating room over there. And they're like, what is this? Well, that's a draw over and that's a bottle of ether. Get busy, Well, where's my pulse ox? You don't get one. All my bells and whistles are gone. And, here we go. And if you historically look back, since it's been around for so long, they were doing surgery safely, without all the bells and whistles, because one of those things is ether is a very safe, anesthetic. And it's got a very safe profile. And if you combine that with the fact of, you are not an anesthesia provider, which is normally what we're talking about these times, is that it is safe, much like ketamine is safe in the hands of people that don't do this every day. It's got a much safer profile to it. Now, the benefits of ether, so to speak, are one, it's a sympathomimetic. I like to think about it like as the ketamine of inhalational anesthetics. Ether's very good in high risk patients, trauma patients, those kinds of things, because being a sympathomimetic, it increases heart rate. It keeps blood pressure up. It's a respiratory stimulant. It causes, people to breathe. It bronchodilates. Okay. Those are good because a lot of times you don't have supplemental oxygen to give to a patient in a lot of these other countries. It has prolonged post-op pain relief. So if you don't even have narcotics at your disposal, ether itself has a lingering effect as far as pain relief. It's field expedient. So a lot of the signs that we look for, are we doing this properly, are things you can look for in the field, which is very important. And one of those things is, if you look at Goodell's signs, I know we talked about that in the past, but the stages of anesthesia, how deep is this patient? I don't actually need a really wazoo monitor to figure that out. I can see what their eye reflex looks like. I can see what their breathing rate looks like, their quality of breathing, muscle relaxation, things like that I can see in a field environment without all these extra types of monitors that I may be used to in the operating room. So it gives me a lot of great things along those lines as far as it being used in the field. It's incredibly cheap. You can produce it locally. There was an article not too long ago in the National Institute of Health where they were actually a proponent of some of these developing countries to produce their own ether because you could afford it because you can do it locally. Just like Mike said, you can do it in a high school chemistry lab, type of a deal. You don't need truly, very complicated delivery systems. Back in the day, they were just literally doing this with putting, basically some cotton gauze over the face, and pouring the ether gently. There's a technique to it, but, pouring the ether over the mask, and that's the open drop, ether drop, mask technique that you can use. You can use something as simple as an ether jar. And then the next kind of military side of the house was the draw over that, for those that went through the schoolhouse back in the day actually got exposed to. I'm not sure if they're still doing it. I wish they were. But exposing guys to a draw over, because that is an amazing piece of equipment that is very, again, doesn't require all the bells and whistles to get that thing to operate and to be able to deliver something. Ether was the basis of the actual draw over machine. Now you can use other anesthetics in it, but ether was its actual basis for that machine. So then you might say, well, gee, that all sounds great. What are some of the drawbacks? Well, we got a couple. One is, it's highly flammable, man. Like even to the point of if it gets exposed to too much sunlight, it can form crystals and it can be explosive. If you guys have ever blasted out your carburetor on your car back in the day with engine start, it's ether, and so it is highly flammable. And that is why one of the big reasons back in the 60s in the States that we moved away from it to the anesthetics that aren't flammable, especially because surgical techniques started to go down the road of electric cautery, and you do not want flame or spark around ether. Believe me, you know what I mean? So that's why it fell out of favor in the States. But, you know, if you're in a place where you don't have electric cautery and all these things, everyone understands, like, no, there's no smoking in the operating room, really, you know, that kind of thing. It's great, you know. Now, the other thing is it's very pungent. If you've ever smelled ether, it's got a very pungent smell. So when you are doing like a mask technique, you have to tell the patient, because they're going to kind of resist the smell of ether, especially that kind of initial phase. And in fact, way back in the day, chloroform, which I'm sure everyone's seen on the old movies, you know, you pour the chloroform on the rag and hold it over the guy's face to knock him out. Chloroform was used to set it up for ether. So you would put somebody to sleep with chloroform, but then you would switch to ether just to make it easier on the patient. So it does have a very pungent smell. Doesn't mean you can't just use straight ether, but, you know, it's just something to remember. It's got kind of a slow uptake. So if you are really doing general anesthesia to go from, like we are now, awake to a down to stage 3, kind of that plane 2, plane 3, where we want to do general anesthesia, it can take, you know, 5, 7, 10 minutes of time. So it's a longer time frame to get there. And that's, again, in the operating room these days, time is money. And so the other is true on the backside as far as waking somebody up with ether that's been under it for a while. It's going to take longer for it to wear off, you know, kind of a deal. But a lot of times in field environments, that's not your concern. You know, you're not trying to get the next patient in. The next patient is like, really kind of, this is a one-off thing a lot of times while I'm doing it. It will cause secretions in the airway, so you need to be aware of that. And then the other thing is post-op nausea and vomiting. Ether was very notorious for, you know, people would stay in the hospital for days after surgery, like back in the 50s and 60s. It wasn't same-day surgery back then. And one of those things was, you know, people get pretty nauseous. Not everybody. But that was one of the kind of the setbacks with ether as far as that goes. So, you know, that's kind of a pros and cons approach. But, you know, again, I got to tell you, one of the big things, again, was the field expediency of it, the availability of it, or the ability to possibly produce it yourself. The safety profile that it has, especially in people that don't have as much experience, the ability to deliver it in multiple different ways, in, I guess, in ghetto ways, you know, just gauze over the face kind of a way, gives you options when you may literally be out of options. I don't have any IV anesthetics. I don't have ketamine. I don't have IV tubing. I don't have syringes. They used to do everything with just some gauze, a bottle of ether, and nothing else. You know, there was maybe a stethoscope, maybe a blood pressure cuff later on, but respiratory rate, you know, heart rate, and vigilance of the person that was doing the anesthetic to get some very complicated surgeries done. So that's kind of it in a nutshell.
All right. Well, I mean, the medical grade stuff, like, it sounds very helpful in the right patient in the right situations.
Mm-hmm.
Using your engine start gas.
I'm back in high school now. Okay, where are we going?
If I had to guess, there are some other complications with that. Like, they're not just using that to spray gauze on and then push it over somebody's face.
Yeah, and so the interesting thing is, typically you don't want 100% ether either. That's the other part. Especially, let's say you're doing the mask technique where you've got the gauze, you know, kind of over the face. And the reason for that is the boiling temp of ether is 94 degrees, you know, which is pretty low whenever you're looking at things. And so one of the problems is, as you're pouring if you were pouring pure ether onto the gauze as they're breathing, it will literally form ice crystals in the gauze to the point of where it will make an ice dam, and you can't breathe through the gauze at all, because it literally freezes the gauze kind of solid, kind of a thing. So when you say medical grade, a lot of times, that ether is 98% pure, 97% pure. The other part of that being ethanol normally, and the alcohol, the ethanol in it helps melt any ice crystals that might form from the respiratory warmth of the air that's going through and the evaporation of the ether side of the house. Now, as far as making it in a high school lab, you can get just as pure as far as that goes as somebody can making it in some fancy factory. That's not a problem. Where you can run into difficulties if someone is trying something really ghetto, again, like I'm going to take, I don't know, you hear about like brake fluid or things along those lines and mixing it with water and what am I going to get? I've never done that. I'm going to be straight up. I've done some wazoo stuff, but I've never done that. However, I have heard, and I think other people have heard, like you can get byproducts that are released from that could be toxic. Okay. And so I wouldn't recommend going that route. I would recommend going the route of at least, distilling it with some kind of a, chemistry type setup if I'm going to distill it and to not make it 100%. Try and stay in that anywhere from 96 to, I'd say 96, 98% ish. And that would also help, not form those ice crystals if you're using it over that kind of gauze technique. So, yeah.
Yeah, I think if it's all right, I'd like to jump in there. Yeah, that first do no harm is the most important thing for all of us, right? I mean, especially in our profession and especially, I'm a caveman in medicine and that's the last thing I ever want to do is harm to the patient in any way, shape or form. Just to climb on a couple of thoughts that Brad had too, if that's all right. It's ironic. We talking about historical medicine a little bit. It wasn't, but maybe 4 or 5 years ago, I had a medic in Eastern Africa at a reasonable trauma 1 center for the location. And he was in the operating room looking at that, and it was a decent setup. And he sent me back this picture, and he's like, "What is this thing?" And it was a draw over machine, Dennis, and it's, maybe we should think about, cultivating and nurturing and educating our medics and physicians and PAs and nurses in a little bit of this, especially when they're going out into the world and they're not going to find the same standards or expectations that we have here at home. Another thought to some of Brad's points, especially in the Indo-Pacific, is quality of pharmaceuticals. They have a significant issue in the Indo-Pacific with where the pharmaceuticals are coming from and what the quality control was behind them. So there's no expectation, there's no prediction, there's no understanding of just what your drugs are going to do or what they're not going to do to a clinical standard. So that would be a significant concern, I think, in this aspect too. Brad talked about flammability of ether, and I've got a great story I'd love to share with you on this. My dad was when we talk about historical medicine, Dad loved, and he had this real strong interest in maggot therapy, maggot debridement therapy, and also ether. But here in North Carolina, I know they were running an unconventional hospital scenario, and they were using ether. And throughout the whole scenario, it worked really well. And some medic obviously did the wrong thing and poured the ether down the toilet. And the next guy that came in, of course, they all smoked back in the 60s and 70s and threw a cigarette butt into the toilet. And the next guy that came in to go to the restroom very quickly learned how flammable ether is, and more importantly, that ether burns clearly. You can't see ether when it burns, and it burns high as well. So those are all real strong lessons, just to use a narrative to kind of drive a point home there, I think. But yeah, just wanted to share that.
No, I appreciate that.
Well, and I'll caveat one other thing to that story, because that story actually went a little further into another area of anesthesia gas. And I know we talked about this a little bit last time, Dennis, and ether in particular is heavier than air. Okay. And so when you are doing these techniques, back in the day, guerrilla hospital kind of stuff, people were doing surgery by, hanging a lantern, on the post in the barn, luckily they were hanging the lantern a little higher than the ether was floating up towards. But if that lantern would have fallen on the floor, they would have learned that all the ether was on the floor. Ether basically will settle and it will travel across a tabletop, and then it will settle down to the floor, much like you used to see in the old movies of chlorine gas in World War One. Now it was green and you could see it, seep down into the trench. Imagine if the ether was colored, you would see it down around the floor and things along those lines. So it has a unique ability to seek out flame of any kind, cigarettes or lanterns or whatever ghetto setup we've got going on. So keeping everyone informed. And I even talk about, like, let's say we're in a safe house and the kitchen is the place to do surgery. I hope you don't have a pilot light going on the stove in there. Things you don't think about, the water heater in the house, that has a, open flame pilot light, things like that you don't really consider. And the fact that it settles, so not only is that a big deal, like with flame, but it also has an effect. If, let's say, I'm working on a casualty and I drop my pencil that I'm recording with, and I go down on the floor to find the pencil, if I'm down there on the floor looking around too long, guess what? I may not come back up, kind of a deal. So I always tell people whenever they're doing those techniques of, pouring the ether on the mask, don't have your face down here, like, is it working? Is it working? Because guess what? You're getting it too. And it can easily, you can go down to stage 2 or 3 with them, kind of a deal. So luckily you'll come back up pretty quick, but yeah.
Yeah. Somebody picks you up anyway.
Yeah. Food for thought.
Just from a little bit of experience, I've been lucky enough just to be part of about, I don't know, half a dozen ether labs. And you will learn, we did not, we did not induct anesthesia, with ether, because of that excitatory phase. That first 10 minutes during stage 1 is so prevalent. But we did so with IV anesthetics, and then we went to an ether jar, basically a very primitive draw over, based on concentration and time on the patient. But over a 2-hour period, it works extremely well. And the great thing about that is, just like Brad said, you see very clearly, you see every stage of Goodell's phases, just like they're poking you in the eye. It is blatantly clear exactly how that patient is reacting to that gas. And it's discovery learning that you just can't measure. I mean, it's so valuable to have something like that if you ever have the opportunity to do that. I know not everybody has the opportunity to do any type of ether lab, but I would always recommend searching that out, or asking someone, or getting more expanded knowledge on that. When we do advanced courses, especially with the surgical teams, we always try to grab the anesthetist and, hey, let's go talk about ether, and let's all make an ether jar together, and let's just talk about it. And a lot of times, even those most renowned professionals have never done it before. And all good change starts locally, so if we start garnering that type of education, I think in our communities, it'll expand greater, and will give those professionals even more understanding. And it goes across the board. ICRC, the humanitarians, operational requirements. I think, the value of just that education is probably immeasurable. But again, to Brad's point, this might be a good point to go back to those PFC standards when we talk about actually setting up a procedural site or a surgical site. What does that look like? What are we trying to do and mimic? And we always, as you teach, Dennis, we always try to mimic that highest clinical standard at all times, right? We don't do historical medicine or improvised medicine because we can. We do it because we have to. And when we do it, we try to attain those clinical standards as closely as possible every single time. Make that room look like an operating room or an ICU. Have good natural air, or a natural airflow and ventilation. It's clean, it's dry, it's well protected. And then also think about those operational aspects that Brad was talking about. Your time in anesthesia might be doubled by his time coming out of anesthesia. So you're not moving very quickly here. You're going to need some surgical and some clinical stability in order to treat and recover this patient after their procedures. This is not like a regional block. You'll be able to do a regional block, maybe do a little bit of sedation on the patient and do a procedure. And that's a one-man operation or one-woman operation. You can't do that here. With ether, you're going to need at least 2 people, if not 3. And then just be hyper vigilant about your hypothermia requirements too here, because ether does lower that hypothermia threshold a bit. So just keeping in mind with that. But yeah, just, thinking about trying to attain the very best clinical standards in the worst possible situations.
Yeah, one of the things from the educational side of it too is that Goodell's signs, the stages of anesthesia, happen every day in the operating room. They're not perfectly matched to what ether is, but it's really, really close. And you can go up into the operating room and see those signs without even having to do the ether lab. You know what I mean? And one of the things that happens a lot of times is guys come to the operating room and they're there to intubate. So they see a patient go under anesthesia, they intubate, but then they leave, because they're trying to get intubation. So they go for the next one. What they don't see is them coming out of the anesthesia at the end. The trick to that is stage 2 of Goodell's signs. That's your danger zone. Okay. And what we do these days is with IV anesthetics is we take a patient from totally awake, pass right through phase 2, all the way to phase 3 in just a second. Okay. And then you intubate them. And then we've got the gas going before they come back up. So they stay down on that stage 3 level. Okay. So you don't see normally stage 2 when people are going to sleep. So guys really haven't seen it. Where you get to see it is when they wake up. Everybody has to come through stage 2 waking up. So things like that disconjugated look I talked about before with when you pull back the eyelids. Once you see that, you're like, I will never forget what that looks like. Holy crap. You know what I mean?
And Brad very accurately calls that gecko eyes. And that's how I never forget that. Never forget that.
It's like, you will never forget what that looks like again. So seeing that, you can just go into the operating rooms. They're like, I just want to see some wake ups today. I want to see guys waking up out of anesthesia. And I want to be able to identify what stage 2 looks like, because I'm going to see that just using ether by itself. They're going to have to go through, start at stage 1. They're going to go through stage 2. So you're going to see the strange eye movement, the breath holding, the almost kind of like choking movements. And that's kind of what freaks people out and causes them to back off, But if you know what that is and what's going on, I got to keep going. And I want them down to this stage 3 level when the eyes come back to look more normal. The breathing starts to become more automatic. Everything starts to calm down. And then this is where I want to stay until I'm ready to wake them back up, kind of thing. And that can be really key without even having to, say like, hey, can we run an ether lab? Ether labs are great if you can do it, but you can just walk into the operating room and see that stuff every day. The other thing I'll say too is, Mike pointed out, like, regional block, I just do this one-man show and then kind of move on thing. People a lot of times think ether is only for general anesthesia. The thing about that is you can do everything with ether. And what I mean by that is you can just do conscious sedation with ether. Okay. And it's great. And you got to be honest, man, most of the stuff that we're doing in the field, we're not taking an appendix out, right? We're not going full bore a lot of the times. We just need this person to calm down for a while to set the fracture or to, stitch something up or, whatever it is. So a lot of times you can accomplish that by, if you do have an ether jar, is let them breathe on the ether jar. And trust me, when it's like a fentanyl lollipop coming out of their mouth, it's like once they get enough, they kind of put the jar down or they fall asleep for a minute and then you're working and then, they kind of wake back up and they're like, oh, I got to, and then they start breathing on the jar again and the same thing happens, The Australians have a cool little thing called a penthrene whistle. And it literally looks like kind of like a kazoo kind of thing. That's anesthesia gas, by the way. It's called pentherine. And that's what that thing is. That's their fentanyl lollipop. They give it to you, especially if you're in the outback somewhere. You don't have to start an IV or do anything weird. You just hold it up and they just start sucking on the whistle. And then they get sedated enough, and then the whistle falls out of the mouth, and then they wake back up when they want some more, and they breathe on the whistle. Ether jar is very similar to that. Whenever, you just need to do conscious sedation and not have to go all the way through and go full bore all the way to a general anesthetic. That being said, the great thing about that is the less time they're inhaling the ether, the quicker they're going to wake up and kind of be more with it. Now, again, like Mike said, it's going to take a little bit of time, but you're not waiting like hours and hours and hours, So I think sometimes people are like, oh, I got to go all the way with this. It's like, no, actually, I could have just let them breathe on this jar for a few minutes, and then they would have knocked out. I would have set the fracture or whatever, you know what I mean? And no harm, no foul. So again, anyway, food for thought, but yeah.
No, of course. And what you kind of reminded me of, talking about using IV narcotics to put the patient down and then essentially use the gas to maintain for the duration, and you start waking them up.
Mm-hmm.
Just like you guys remember in like survival school, they told you to start going ugly early. I see this a lot is that providers, they will continually use the thing they're comfortable with until the supply is exhausted.
Right.
And now your back is against the wall.
Right.
Versus understanding my supplies are dwindling, I'm going to start augmenting it with this other thing that I know can accomplish it, but I would rather not have to. And slowly kind of titrating that into my, whatever my practice is now. In that case, my IV narcotics are dwindling. I can use that to get the guy where I want him to be, where I'm comfortable, and to start titrating in some of this ether until we're about done. And then maybe I pick up with my IV stuff, or I just let him ride and wake him up. However, you want to play that game. But I think that it seems like a good idea. I don't know. What do you guys think?
Yeah, personal opinion, real quick, Brad. I think quality healthcare, quality medicine isn't always about technical proficiency. It's more about systems.
Mm-hmm.
It's more about all the logistics that go behind it. It's about the PACE plan, having a primary plan, an alternate plan, a plan A, plan B, plan C, and being able to coordinate those with the availability of resources that you have and what your priority resources are. And maybe you want to save your best antibiotics or your best anesthetics for another patient. So it's that quality healthcare provider, especially in the austere setting, that recognizes that it's not always about medical technical proficiency. It's a lot more about systems. It's a lot more about decision making. It's a lot more about constantly risk mitigating with every decision we make. Brad, I'm sorry. Go ahead.
No, yeah. And I would say this too, because I always tell people, if you ever are in a prolonged field care environment or long casualty evac scenarios and things along those lines, trust me, you're going to run out of something. It's going to happen, kind of a deal. The thing that saves you over everything else, it isn't medical, it's logistics. I swear to you, every single time, it's the logistical side of the house you've got to solve those problems. Thinking about those things early, like Mike was talking about, is like, that's key, is like, why am I using, an howitzer to kill a squirrel when I can do it with a 22? What I mean? And it's like, that doesn't make any sense, kind of a deal. Not to mention, trust me, I'm all about TIVA. I was the dude that brought it in, you know what I mean? But maybe maybe I can't afford to burn up all those IV sets. Maybe I only have so many bags that I can use or whatever that is. And now all of a sudden I've got this mason jar with a couple of tubes coming out of it with a liquid that I can produce, and it's cheap and I can get my hands on it. It's like, as long as I know how to do it, I mean, why wouldn't I do it? And I'm sure someone's out there right now going, well, I don't care. You know what I mean? Because to me, the thing that drives me absolutely batshit crazy at times is whenever I'm working with students and they're like, well, I'm just going to nerve block everything. Really? That's your answer? You know, well, they're shot in the abdomen, pal. You ain't nerve blocking that, you know what I mean? Or whatever it is. It's like, how is it that we got to the point where everything's so absolute? You know, it's like, well, I only have to carry blank and blank if I just do nerve blocks. It's like, that's retarded, dude. That is like straight up the most retarded answer I've ever heard. It's weak answer, you know, and on top of it all, it's lazy, to be honest with you. I personally want multiple tools in my bag, man, you know, because I don't know what I'm going to run into. And if I just spend a little bit of time to put the effort in, you know, and I'm ever in a really bad scenario, and I've been in quite a few, you know, and it was like, I have to be able to think my way out of this problem. It's not an algorithm. This is what happens in between all the boxes on an algorithm. That's what prolonged field care is. The algorithm's over, man. You know, you have to problem solve to figure out if you're going to get out of this bad situation, kind of a thing. And like Mike said, it's like, you better start thinking about that early. Otherwise, you're just going to burn up all your good stuff. And yeah, you really are in a pickle because, you know, you were just following some algorithm because somebody said that's how you do it, you know, kind of a thing. So anyway, not to get on a soapbox, but yeah. Did I get on a soapbox? I think I did.
No, you're good. You're good.
No, that's okay. I was waiting to get on.
There's an old operational axiom, and I think maybe the medical community writ large, especially really large, you know, could learn a lot from it. You know, amateurs think tactics and professionals think logistics. And that's really what makes the difference right there. Just like Brad said, having all those tools in your toolbox, being familiar with them and knowing those drug profiles, and the devil's in the details is really what's going to make the difference there. It's not always about technical proficiency. It's more about logistics.
Yeah. No, I absolutely agree. From all the prolonged scenarios that I've been part of or taught, it always comes down to like, crap, that's my last syringe.
Yeah, exactly. Yeah. Yes. Is the syringe fairy around? Who's going to?
It wasn't too many decades ago that the tac set had glass syringes in them. So yeah, and resharpenable needles. So yeah,
you know, but I can easily see people, you know, wanting to do regional blocks because it's cool, it's sexy. You know, I have a technique that maybe somebody else doesn't know how to do, which instantly makes me smarter than everybody else around me, right? And I see, you know, medics, really any provider, they're like really hungry for the new technique, the new drug, the new gear, the new whatever. But you can't buy your way to success in this type of environment. You have to know the basics inside and out, upside down, backwards. And that gives you the freedom of maneuver to be able to incorporate, you know, this random stuff that you come across. You're like, wow, you know, my sedation drugs are starting to wear off, but I have Benadryl. I can probably start incorporating that. One, he won't be really itchy, and two, he'll probably sleep for a little bit longer. But my risk of badness probably a lot lower. You know what I mean?
Yeah.
And I can use those things to try and extend things out. Hopefully, I make it.
Yep.
You know, and you know, somebody hands me a jar and they tell me it's ether. Okay, well, you know, that wasn't part of my school, and nobody ever showed me that. So, but I can Google some pictures. I can have some basic understanding. Hopefully, I call Brad. I'll put your phone number in the description.
Yeah, do that. Yeah, that's great.
So I can call back. You know as well as I do. Our idea bad isn't everybody else's idea bad.
Right.
You know,
right. Right.
There's there's a draw over in East Africa. You know, there's small villages in South Sudan or in India that do ether every day. They do it every day. So if we ever find ourselves in that position, then we have to use good judgment, exercise a whole lot of observation, and learn if we can.
I would think if you're running into a clinic that has a draw-over machine, unless it's like just literally covered with dust,
Yeah.
somebody probably was using that.
Yes, sir.
Maybe, put your ego down there for a second and ask them, like,
Absolutely.
how did you use that?
Oh yeah, because they'll tell you. They know how to do it. Believe me, man. You know what I mean? And you absolutely will learn, like if you can put your ego to the side, and there's going to be cringe moments, if you've never been in those scenarios where, oh my God, are you serious? You're really going to do that? But they do it every day, and
then they look at you and ask you, why don't you know this?
Yeah. So, yeah.
But likewise, you can trade information. They show you this is how we do it. Well, maybe I have another toy or I have another bit of knowledge. Let's combine our knowledge and we can just raise the level of care.
Yeah, absolutely. Yep. And that resistance, to learning or change, it's not just medical either. It's cultural. I think, guys who have, volunteered or done some time in Ukraine will tell you, anybody over 26 years old does not really want to see an ultrasound machine over there because it's against anything they've ever seen before, and they don't want to learn about it, and they just want to keep doing things the way they did it because that's their comfort zone, and that's understandable. But that's, it's an entirely different arena and environment than what we're used to.
Yeah, absolutely. Well, awesome, guys. Is there anything else you guys would like to add to this? Brad?
I would just say, I think, we've said it before, like, this isn't a how-to video. You know what I mean? This is a discussion about all this. And really what I hope that it sparks, and I know Mike feels the same way, Dennis, you and I have talked about this before, is it sparks people to go out there, do research of their own, do some historic reading. There's a couple of videos I said on the last podcast on YouTube from 1944, I think it was, of ether drop anesthesia, very properly done, training videos back then for med students on how to do some of these techniques safely. And to just to say, like, obviously on the PACE plan, this isn't at the top, this isn't the B kind of a thing. However, this may be what you've got, and to spend a little bit of time going out there doing some research. Like I said before, try and get into the operating room and identify the stages of anesthesia for real on a patient, kind of a thing, what that looks like, because they translate very well to what ether would be. And yeah, I hope it sparks interest, because, like I said before, when the National Institute of Health is coming out and saying all these developing countries around the world should highly consider producing their own ether and it being the primary anesthetic, where anesthetics don't exist out there. If you're doing any kind of expeditionary medicine or deployment medicine, or you never know what you're going to walk into, and I'm sorry to say, you're probably not going to have internet access to look up the YouTube video then. You know what I mean? So doing that beforehand, put my number on the screen. I'll talk to you about it. So, but yeah, no, that's my 2 cents, man. Yeah.
Dennis, good choice. I think there's one other person in the entire world I would rather do, or I would do a broadcast like this with than Brad. I mean, Brad has taught many, well above their scope, and I appreciate that. And I'm glad to do this. No, I agree with Brad. I hope that this would inspire some research and some learning in historical medicine. Brad and Nick did a great article on this in, I think, the summer 2018 edition of the Journal of Special Operations Medicine. There's an unconventional medicine series in there that's really good. Marty from Australia did a draw over article in that series as well. And those are very good, short acting articles on which you can learn about these things. Another thing I'd like just to say is just, again, improvised medicine or historical medicine, we do it when we have to, not because we can. And that's real important. No harm to the patient. Highest clinical standards at all times, having a professional responsibility, not to lecture anybody, but it's the reality of our profession. And just seek out the opportunity to learn more, especially instructor cadres, the anesthetists, surgical teams, or independent corpsmen. Not everybody can do an ether lab. I get that. But those specialty audiences that could pass that knowledge on, I think it's pretty critical. Because like Brad said, learning from stage 3, plane 1, the difference between plane 1 and plane 2 is your reflex, your blink reflex, and from stage 2 to stage 3 is diaphragmatic. And being able to see that with just a simple on and off of an ether jar, you cannot learn better than that. You cannot learn better from that experience, I think. And especially for the people that pass that on, that's really valuable. So thank you.
Oh, thank you guys. I really appreciate it. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.